Tyler Henningsen, Senior Director of Practice Advancement at the American College of Lifestyle Medicine. On behalf of ACLM, welcome. We're thrilled to have you with us for today's webinar, where we'll be highlighting some of the most innovative ways lifestyle medicine is transforming healthcare in the great state of Texas. As our speakers share their work, feel free to drop your questions and comments in the chat. Some will be answered there directly, and others will be saved for live Q&A at the end. I will quickly flag there are no disclosures for today's webinar. And sorry, our slides aren't quite advancing yet. Okay, there we are. And thank you. And showcased on our learning objectives slide are a few of the learning objectives for today. By the end of the session, you'll hear key examples of how healthcare systems in Texas are using lifestyle medicine to address chronic disease and improve health outcomes. We'll explore some practical innovations that are scalable, support high-value care, and contribute to lasting systems change, and especially in ways that improve access and reduce costs in diverse communities. With that, I'm super honored to introduce today's moderator, Dr. Padmaja Patel. Hailing from Midland, Texas, she serves as president of the American College of Lifestyle Medicine, as well as chief medical officer at Nudge Health. A true pioneer in the field, Dr. Patel has led the development of innovative care models applying lifestyle medicine to chronic diseases across a variety of in-person and virtual settings. She's also a strong advocate for integrating lifestyle medicine across health systems, improving care for patients, employees, and entire populations. We're especially thankful to have her with us today, moderating this event as a Texas-based leader and change agent. Dr. Patel, thank you for being with us today. I'm thrilled to turn things over to you.
Thank you, Tyler, for your kind introduction. And hello, everyone. Welcome. I'm so glad you could join us today as we shine a light on some of the inspiring bright spots in lifestyle medicine right here in Texas. For me, this is a bit of full circle moment. About 10 years ago, I first encountered lifestyle medicine at a Food is Medicine seminar in my neighborhood in West Texas. What began as a community conversation soon grew into a nonprofit initiative and later into a partnership with a local health system, Midland Health, to establish one of the first comprehensive lifestyle medicine centers in the country. What excites me today is that these efforts are no longer isolated experiments. Texas has become home to a number of bold initiatives, dedicated teams, and communities proving that lifestyle medicine can be implemented at scale. From health systems to local organizations, these stories show what is possible when we align evidence, passion, and collaboration. So what is lifestyle medicine? Likely you may already know. The field of lifestyle medicine is centered around using a therapeutic dose of 6 evidence-based pillars of health behaviors, which include optimal nutrition, regular physical activity, restorative sleep, stress management, positive connection, and avoidance of risky substances. Next slide, please. As the nation's only medical professional association representing the entire interdisciplinary field of lifestyle medicine, the American College of Lifestyle Medicine represents a galvanized force for change. Members are united in their dedication to identify and eradicate the root causes of chronic disease with the clinical outcome goal of health restoration. ACLM closes the gap in evidence-based education in lifestyle medicine across the spectrum of pre- and post-professional training. Along with training and support of its members in their individual practices, ACLM advocates lifestyle medicine as the first and optimal whole person treatment option for all people, mitigating much of the non-communicable chronic disease epidemic. Next slide, please. ACLM has experienced tremendous growth since its inception in 2004. It has been recognized as one of the fastest growing medical societies in the country. Next slide, please. ACLM works with hundreds of aligned partners whose services, vision, products, advocacy efforts, and solutions address the burden of chronic disease and support healthcare transformation, including health plans, accountable care organizations, health systems, nonprofit organizations, digital therapeutics, medically tailored meal services, and other aligned organizations. Next. Which brings us to Texas. Here is a quick snapshot of our presence in Texas. We have 834 active members, 304 certified diplomats, 8 health system partners, 14 academic institution partners, and over 2,400 participants enrolled in the Lifestyle Medicine and Food as Medicine Essentials course. It's a strong and growing community and a real innovation hub for the field of lifestyle medicine. Next slide, please. As our presence in Texas grows, we are building something bigger than just numbers. We're forming a collaborative impact network. This includes partners across health systems, academic institutions, and community organizations who are ready to innovate together. We're looking for others who are ready to co-create pilot programs, lead education and training, and embed these approaches into care delivery and systems level change. If that sounds like you, we want to connect. Please reach out to us. Next slide, please. We would love to engage with you all at our annual conference, which is in Grapevine, Texas. You can also join us virtually if you're unable to join in person. Next slide, please. I'm thrilled and honored to introduce 3 incredible speakers for today's event. Dr. Jacqueline Albin, who serves as a Director of Culinary Medicine at the University of Texas. Marcy Madrid, who serves as Vice President of Community Health for Midland Health, which is my hometown. And Dr. Richard Chamberlain, who serves as Managing Director of Public Health for the City of Laredo. These 3 visionary leaders are driving bold, innovative lifestyle medicine approaches that are reshaping care and delivering real results in their respective settings. We hope their stories inspire you and offer blueprints you can adapt and apply to spark a similar impact in your own setting. Next slide, please. I'm thrilled and honored to turn things over to Dr. Jacqueline Albin to get us started.
Thank you so much, Dr. Patel. I'm glad to be with everyone today. And my first slide is actually a little bit of an ode to Texas. So if you are not familiar with Texas, I imagine we have a lot of fellow Texans who've joined us today, but we have such a large, diverse population. We are roughly 10% of the entire US population. And yet at the same time, we have some big problems we're facing. We are the 2nd highest food insecurity rate in the United States, just behind Arkansas. And we have a ton of higher education where we're shaping the next generation of learners and thinkers. And then we also have every possible application of clinical care across different types of health systems and practices. So I see this as the perfect soil to build novel strategy that could work anywhere. And so I often tell people when I share the stories of the things that I'm doing here in Dallas at UT Southwestern, we are overcoming big problems, but that leaves opportunity for big solutions that can really be applicable in other places. So I also want to frame that my brief overview of my story, which I'm going to tell you in a way that I hope makes it really practical for you to say, how could I take this? How could I choose a piece of this and begin or continue the work that I'm doing where I am? But it's so critical to know that this is not a one-size-fits-all approach. There are multiple ways for us to do better. And if we get too rigid about what it has to look like or what curriculum we use or what recipe, then we lose the beauty of tailoring and building to our local communities. So that's a big part of my story, is how we do this to fit where we are. are. And so I encourage you to think about where you are as the first part of this. It's going to have its own flavor. It's going to have its own spice, and it doesn't have to be exactly the same as what any of us have discovered to work in your own journey. And it's okay to have that open mind along the way. So on my next slide, this is our roadmap for the next 10 minutes or so, where I'm going to go through these core themes with you. So when I looked back on my journey in building lifestyle and culinary medicine implementation, enthusiasm, and presence at the University of Texas Southwestern, it went in this order for me. And there's some overlap, as there always is, but I hope you can pick one or two of these areas and say, that's where I'm at, or that's what I need to do to take the next step. So we're going to talk about how it often begins with recognizing that something is missing, and I'm going to tie that to personal experiences. So when I was trained in internal medicine and pediatrics, I didn't realize how much food mattered for health. But my roots are actually in farming. In that little not super high quality picture, you see my paternal grandfather's farm, which was in Lockett, Texas. There are lots of small farming towns in Texas, if you're not familiar, but agriculture is a huge part of our culture. And I'm the little girl in the red hat. My little sister's also in that picture. And we grew up knowing where our food came from. And one of my favorite memories is my grandfather would sometimes pick vegetables in the backyard and then teach us how to cook it, because it was a powerful part of how he showed love to the family. So that was in my roots, but I didn't know how much it mattered until it became personal. So you see my family and the adolescents who mostly eat the delicious vegetables I feed them. But we began our journey when my husband was diagnosed with celiac disease, which was about 16 years ago. And he was told that he needed to eat a gluten-free diet, which was not real easy to do in 2010. There was not a lot of information about it. And I realized something huge was missing from my training and my clinical practice that I would have to offer my patients. My son also has celiac disease, and then other family experiences brought me to the recognition that I had to fill gaps that allowed me to do something different. And so thankful I found lifestyle and culinary medicine, which has empowered me to deliver care to my patients in a very different way. So I encourage you to think about what your story is. I began teaching nutrition at our medical school because I brought my lunch, and people saw that I ate differently and they wanted to know more about that. So sometimes it's as simple as living out your own story and letting people ask questions. So the next part of this is critical. This is the homework. Who remembers homework with fondness and warmth? Not necessarily, right? We often think of homework as busy work. We want to skip over it. We want to pass through it. But if we do not do the background work, we often start things that are already there or that are not resonating with what's already there. So you have to identify three things. Are there programs, not just in your health system or in your clinic, but in your community? Who cares about the same things? Those people are stakeholders. The stakeholders are not just the people with money or power. They're people who care about this. And so finding other people along the way, and then also being sure that you aren't assigning need to your patients or the population you want to work with, but you're actually asking them, what is it that you want and why? Because sometimes people want something, but we are step 3 or 4 down the line, and we have to start at step 1 if we want to equip them to be successful. So that homework is vital. Don't do anything before you take a closer look. And we all want to jump to, this is a picture of my dietitian partner, Millette Seiler, and I, she's built everything alongside me. That's the friends part of this. Finding a friend along the way is vital to stay focused. And we're in a community kitchen where we offer patient cooking classes, and I'll tell you more about that. But we didn't start there. That happened 8 years in to where we started. And sometimes things are slow to build, but if they're rooted in the right reasons and the right questions, we'll be successful. And then I hope you can reflect on why you want a program. For most of it, it's because we see a gap or we want to fix something that's broken. And if you understand the why and you root your efforts in that, it'll always bring you back to that as the core foundation. So in the next slide, I want to reflect on the power of training the next generation. This is where we started, and it's a great starting point for many of us because our our medical learners are hungry, pun intended, for us to actually teach this to them. They want something different. They see what's wrong with medicine. And I actually look at this coming generation, particularly the physician trainees that I work with, as the bravest people because they are entering medicine with an awareness of all that's not working and they still want to be here. They still want to solve the problems that we as, the middle and older generations haven't yet fully figured out how to solve. So investing in this does a few key things. Number one, interprofessional engagement is a powerful tool to build momentum across health systems. So we bring dietetic students, medical students, PA students, and many others into a kitchen together, and we teach them how to prepare and talk about delicious, nourishing food. Imagine the power of our patients hearing the same messages everywhere they go in a healthcare system. Their physical therapist says the same thing that their doctor said, that their dietitian said. That's where we can really begin to see change. And then for those of you who might not be in the land of medical education, UME is undergraduate, GME is graduate or residency and fellowship, and CME is continuing medical education. We need stuff at every spot to continue to power people who can do this work. And then the coolest part of this is that our students were the ones that drug us to the community. They said, that's great that you're teaching us, but we want to take it to the community and we want to do it now. And that was what inspired the next phase of our program. So community partnership has to be authentic. And I want to just pause here and have you challenge yourself. Is community partnerships something that you've been investing in if you live on the health system side? And if you live on the community side, you likely have stories of sort of brief interactions or encounters. Maybe there's a health fair, but it takes trust for us to truly work in tandem with our community partners. And I think it is so core to the work of lifestyle and culinary medicine. So I was fortunate that I entered in as a faculty member 11 years ago, and several of my collaborators had already built authentic partnership at Crossroads Community Services. And I'm just giving this as one example of several core partners. So over the years, we built work. We said, what problems are you facing that we can help answer? One of them was, hey, we have fresh produce, and our client choice pantry means people can choose their food, but they're not taking those healthy, fresh produce options. So what did we do? We deployed our culinary medicine medical students that wanted to be in the community, and they started doing samples. Like you imagine what you would get at a Costco, where you can decide, I want to try this because I know it tastes good. So we handed out recipes and samples over several years, collected data, learned more about our community. And we built up many different ways to serve the mission of Crossroads and also learn about our community together. And on the right-hand side, you see two pictures of our brand new, freshly opened nutrition market that is next door to our clinic. And you see the CEO, Bené Watkins Chambers, who has become a friend and collaborator in all of these things, standing next to the kitchen supplies that we were able to get donated. So this beautiful space is actually surrounded by a pantry where we can send our patients directly to get support. And the funding for this work came as a result of perpetual partnership between the health system and the community organization. And it can lead to really beautiful things. So on the next slide, I want you to think about where you could gather data. So these are just some examples of some of the things that we've chosen to pursue. We said, hey, what if we medically tailored groceries in a food pantry? Does that improve health markers? Stay tuned. There's some publications coming about that. We also have asked the question, if you pair a cooking class with a fruit and vegetable prescription, does that increase uptake and confidence and long-term use? What about using community health workers as coaches? How can they be deployed to really provide the support that people need? And then using pharmacies. Pharmacies want to be a partner and they want to be part of delivering food as something that we prescribe. So pilots along the way brought the research data that then gave us an opportunity to go deeper and answer some of these questions. And so I hope that you see that the entire lifestyle and culinary medicine community nationally is working really hard to build this foundation and make it easier for all of us to know what is going to work for our patients. So the next phase, and really something I'm so grateful for, is building up my voice. And I call this make some noise because sometimes it's really uncomfortable. And many of us are not used to saying things that could be a little controversial. And these are just some examples of some team voices that I've joined in with. So one article in the top left in Health Affairs, a group of my dietitian colleagues and my community partners came together and said, hey, when we run food as medicine programs, we can't let this become overly transactional and only about the food. It has to be about the people and understanding who we're serving and what they're facing if we want to see this work. And then we've written about how we have to care about the Farm Bill. That if we really want to make change, policy has to join us. And it can't just be about shifting our healthcare systems. It has to be the whole community. And then I was so honored to actually have my first experience of someone doing artwork, which so creatively brought together a white coat representing medicine into an orchard. And while I believe cooking and food have been undervalued and not taken seriously in many circles, to me, we're changing that by educating the next generation to say this is the first and most important thing we can offer most of our patients. The full circle moment for me was making this a reality in clinical medicine. So in these pictures, you see Millette, my amazing partner in this, doing a demo in a church fellowship hall that we lease the space to run cooking classes that are billable to health insurance. And then you see the kitchen space with one of our medical student volunteers setting up tables where we bring patients to do hands-on cooking, and we're teaching them how to treat their diabetes and high blood pressure and many other health conditions with food and community. We're teaching them mindfulness, we're teaching them movement, and we're really pleased that we were able to share the first report of our model in New England Journal Catalyst, which is open access and free online for anyone who wants to learn more about how this could be sustainable by building it into healthcare systems. And I'm so grateful that UT Southwestern has given me the opportunity to build this unique approach that I think can scale. Doesn't require a beautiful kitchen, it requires community partnership. And when you build that throughout the process, you're ready to go without having a ton of resources. And then lastly, the step 8 is about where do we go from here? You actually have to continually ask this question, how do we expand? And we have faculty who've approached me in the fields I list here saying, I want to bring this to my patients. How do we do that? How do we grow culinary dietitians in our health systems to make this something that more of our patients can access? And some of the ways that we approach this is being ever creative about how we fund it. Yes, we're funding it with clinical billing. We're also always looking for grants and ways to fund some of our research questions. We're always looking for our local philanthropists and foundations to support it. And you have to be flexible. And then the way that you really share is by telling stories plus data. So you tell about the person whose life has changed, and you also share the actual impact at a larger level. And so in closing, I just want to tell you what next steps you might want to take. And I put the Venn diagram here at the top as a reminder that it really helps to take your vision and goals and try to align it as best as possible with something that your health system needs to solve. How can you overlap the problems your health system is facing with lifestyle and culinary medicine as a solution? And they don't think about kitchens first. So sometimes we have to sell why this has so much power. So understand those problems, understand the strengths that already exist in your system, in your team members, in your community, and then begin to align that and to tell the stories in a way that makes sense to people and that wakes them up, because everyone's looking for hope as we navigate the big problems we're facing. Partners along the way is what keeps you going, because none of us have eternal energy when we face obstacles. So I wish everyone many, many successes as you try to find the joy in this work. It is hard, and I don't ever want to sell it as not hard, but you keep showing up and asking. You get many voices to give you feedback. You remain flexible and you stay focused, and you can transform your health system and community in a way that's authentic and true to where you are. So I'm going to turn it over to my new friend, Marcy Madrid. And incidentally, I'm super thrilled to know about the work she's doing because I was born in Midland, Texas. And so it feels really special to know about how they've transformed what they're offering to patients and families there.
Thank you so much, Dr. Albin. I loved so many of the points that you made. I'll probably point out a couple of them through my presentation because they're so valuable and relevant to the challenge I think many of us are facing in this space right now. And so you mentioned in your last couple slides the importance of partnering with your health system. So I've been in healthcare administration for almost 20 years now on the health system side. So I'll talk a little bit about that side of the experience. That's my main role as I'm coming to you today. But as you see in this slide, the other big part of who I am is I'm a wife of almost 20 years. My husband, I've got 6 kids through a collection of adoption and stepchildren and 4 little ones that I've given birth to, but we've got a great little tribe that keeps us really busy. Our picture's a little dated. I will tell you that cute little boy on the left is now 16 years old playing varsity football this Friday in Allen, Texas. So it's a little dated, but they keep us very busy. So much light and excitement and joy filling our lives. But a lot of my hopes and dreams and all of that came to a screeching halt as I became a patient in 2015. I feel like I have a unique experience in that because when you're sitting on the other side of the physicians I had been working with a prescription pad, and it seems like your whole life story and all your hopes and dreams get rewritten on that prescription pad. All the things that I had hoped for, all the things I was planning for seemed to come to a screeching halt, and it was a really difficult time. I understand what it's like to be on the other side with a hopeless diagnosis, to feel like you have no way out. I mean, given an MS diagnosis back in 2015 and still today, there aren't a lot of options or solutions in traditional medicine. There's a lot of prescriptions that you can try to take. There's things that you can take to help with the side effects of the prescriptions, but there's not a lot of hope. So I was thankful. I did start taking the medication immediately. I was shaking. I was getting worse. And it wasn't heading in the right direction. I was told to sign up for FMLA because I probably would spend a lot of time out of the office. But I was thankful that around that same time in the same month, there was a meeting of our health system, several physicians here that wanted to talk about lifestyle medicine and how it was things that were happening within ACLM at that time and what we should do here to represent that. And it was the same month as my diagnosis. So I was personally, privately battling my own health issue while also learning about lifestyle medicine. So I watched Forks Over Knives, which was about all there was in 2015 to educate a layperson on what lifestyle medicine was all about. I read Dr. Scott Stoll's book Alive because that was another reference material I was given in 2015 because there wasn't a lot at the time just to understand what all this was about. I was pointed, thankfully, to Dr. Greger's website, nutritionfacts.org, which these are all resources I still give patients today that come to me with new MS diagnoses and trying to understand the link between lifestyle medicine because there are great resources out there for patients that are not in the clinical medical world to really understand what these things mean. Spoke to several key physician leaders to understand the connection between food and autoimmunity to really start building my own understanding from a patient perspective. Thankfully, I was introduced to Dr. Roy Swank and John McDougall's work at the time, which is great work to point newly diagnosed autoimmune MS patients to because there's so much there. And more than all of that, on top of all of that, my husband and I really had to pray about what to do. The decisions that we were talking about making were against all of my healthcare practitioners' recommendations at the time. It was not very common or popular. It was a really big choice to decide to shift to food as medicine away from traditional pharmacology. But I felt comfortable in that, and I got peace in that through prayer and through all the research that I was inundated with to make the decision right before Thanksgiving in 2015 to get off all of my medication and switch to a plant-based diet. So no meat, no dairy, limited oils, refined sugars, very strict. I was told by Dr. Stoll at the time, and I still tell others at this time, when you're fighting something like MS or an extreme new diagnosis, you have to fight with every bite. And I was confident that I'd be willing to eat cardboard if it meant I could still braid my daughter's hair, because at that point my hands were shaking so much I could barely braid their hair. That was okay to me if I could never enjoy food again, which is what I felt it was coming to as I'm sitting at Thanksgiving dinner eating these very bland foods, and I didn't know how to cook, and there weren't a lot of resources at the time. But we made the switch. My neurologist didn't know what to do with me, so he referred me to UT Southwestern. Dr. Darren Okuda, who was an MS researcher, who also didn't know much about this at the time, was willing to watch me. When I saw Dr. Okuda, it was 6 months later in April 2016, and these are the images that he saw after my diagnosing MRI to the 6 month later MRI. He was asking me what I was eating. He was taking notes in my visit of what I was doing and what was all this about, and why I did this. And he was a researcher. So although he didn't understand it and I wasn't willing to try new medications yet, he was willing to watch my case, and was very interested and started learning more about it and transferred me over actually into his research side, because he was so excited about all this new stuff he was learning about lifestyle medicine. He's now one of the few MS research focused neurologist that is promoting lifestyle medicine in his practice now at UT Southwestern, where Dr. Alban is. So I still see him every year. I'm still a patient, although I'm on the research side. So I get to do everything on his research MRIs, and it's a very different kind of patient visit now, but it's been exciting to watch how his practice has incorporated this more. So now that I'm personally passionate about it, as this happened, I was really excited to get our health system on board. I recognized that we didn't have enough options for our patients. I was only given this option by chance, that I knew the right people and I was pulled into the right meetings. So many other people facing these depressing diagnoses in our physician clinics didn't have that information, and I didn't feel like that was fair. So I got other leaders of our health system on board to do what we could to bring this information to the community. Thankfully, we had physician leaders like Dr. Patel and Dr. State-Nautry, Dr. Sari Nabolsi, Dr. Lawrence Wilson at the time, who were all very supportive of this, who were willing to really get our health system on board and discussing how we could push this more out to our patients and to our employees. We had really unhealthy employees with our health system. We're a self-insured benefit plan. That was a lot of costs that we were carrying on sick days and diabetic, hypertensive employees. So if we could just get our employees healthier, that is a bottom line impact right there that we really worked with initially with our administrators to get them excited about lifestyle medicine. This could help make our employees healthier and reduce our overall cost. So we started talking more about lifestyle medicine and how we could incorporate it into our structure in 2015. We began promoting forks over knives within our inpatient setting to patients who had new diagnoses related to cardiac disease. We worked with Nelson Campbell at the time to bring plant purination to a public viewing to our community, to really start introducing this information to our community, making sure patients that maybe weren't patients yet or friends of family members knew that this information was out there and available, because they may not end up with a physician who knows about it or is supportive at the time. So we wanted to make sure our community was aware so they could start asking questions. We began introducing more plant-based options in our cafeteria and our inpatient meals. We recognized, as we were talking about this more to our employees, we need to give them options when they go to lunch other than fried chicken and milkshakes. So we started bringing in more vegetarian, vegan, and plant-based options into our cafeteria. We actually got rid of the milkshake machine. We got rid of the deep fryers, replaced them with air fryers. I mean to say this on this slide right here, it feels a little disingenuous to give you a list of these really great accomplishments on a clean little slide that took place over several years. This was a messy, difficult process that took the spans of several years, and we're still working through it. So, we cleaned this up to put some bullet points on a slide just to summarize all this work. but it isn't as easy as it looks. Obviously, Dr. Albin mentioned that this is our fingerprint. This is how we did things that made sense for our organization and what we could do. It could look different for one of you. You may have to go about it different. And I hope, if nothing else, you get from this that this started with discussions in 2015. There was a lot of work that happened up until 2018. There's a lot of work still happening today, but it took fighting status quo. It took patience. It took beating the drum in the background when no one seemed to be listening. It took having friends and other people to help stick with you in it and keep the faith and know that you're doing something that's meaningful. And that one person that called you and said you changed their life is what keeps you going to make sure that next one person hears the message, despite the others that say it's too hard or they don't want to do it. So finding that reason to keep going over years of trial and error and messy plans and trying to build the plane as you're flying it. That's what kept us going for a long time. And all the points that Dr. Albin gave are so important to know your why and let that passion drive you forward with others. We did start the Food is Medicine conference from the hospital standpoint in 2016. We opened a community garden to start talking about the importance of gardening and giving people a place to do that if they didn't have it at home. We partnered with the Master Gardeners on that. We formed the Healthy City nonprofit that Dr. Patel mentioned. She was one of the founding members. We realized at the time, which is still a challenge we face now, that healthcare and improving the health of people hasn't traditionally been in the business model of a healthcare system in a hospital, unfortunately. That's what goes back to the title of my slide, trying to transition sick care to healthcare, because we have been in the sick care model for so many years. It really is swimming upstream and trying to rework the whole model to turn into a healthcare system. And that's what we've been trying to do over many years. And forming a nonprofit in our community at that time really helped us take some of that effort and fundraising and money outside of the hospital, which couldn't really make that business model make sense, and put it in someone else's lap and allow community members to get involved and allow us to raise money to put on conferences. That's been a great thing about the Healthy City nonprofit that started in 2017. They took over the Food is Medicine conferences. We had 500 people attend the first one. I mean, we just had great response, great movement. We opened the Lifestyle Medicine Center in 2018 through some of these efforts, collaboration with Dr. Patel, obviously, as she mentioned, to do that. So we did a lot of things. It was a lot of messy work, but it was whatever we could do to prove that there was impact to the health of our community, but also some financial tie, whether it was improving the health of our employees and decreasing our benefit plan, really getting information out to our community, trying to offer new things. So we had a lot of great work in progress, and then COVID hit. And I think many of you may have faced this if you've tried lifestyle medicine efforts. It certainly was a huge stalemate to us. We had to stop all of our public gatherings. Dr. Patel had to take a lot of her wonderfully attended, thriving group counseling sessions to virtual, which was a whole new challenge. Physicians were getting burnout. People were living in isolation. Mental health was increasing more than ever. And I think more than anything, people sidelined health and wellness. That was less of a concern, and the main priority during those several years was survival. And so that stalemated a lot of these great efforts that we had going for so long, and they had to go quiet and we had to refocus. So now here we are today, and who knows when COVID stopped as far as the crisis side, 22, 23, we went through a couple of years there where we felt like things were getting better. I think we all feel like we're fully out of the crisis side now, but healthcare has settled into this whole new world. And we already had challenges before COVID, and COVID exacerbated a lot of those challenges from an administration standpoint. We have more pressure than ever on controlling cost and improving outcomes. If you look at the Medicare Advantage plans and how much they're expanding, accountable care organizations, there's all kinds of new supplemental payment models where Medicare and CMS are trying to come up with new ways to squeeze the cost and reduce resources but still improve the health of communities and put pressure on hospitals. We've got less resources. Medicare's been making cuts to physician reimbursements, to hospital reimbursements over the last several years. There is more scrutiny than ever on physician compensation. The auditors that oversee our business are overseeing physician comp packages more than ever. So as we're asking our physicians to do more and document more and do a better job at coordinating care, we're also trying to balance their compensation, and how auditors are putting pressure on wanting them to see more patients and having more RVUs. It's a huge conflict that healthcare administrators I know are dealing with right now, trying to balance the need to improve community health and do behavioral health resources while still trying to maintain the current practice and pressure on compensation. There's more emphasis than ever on patient engagement right now, because we're trying to improve quality and reduce cost of care, and the only way that we can do that is to get patients engaged in their own care. We can't do things to patients anymore, like surgeries and procedures and pills. That's not working. We have to engage a patient, get them to care about their health, and actually be active participants with us now in their care. And that's a lot easier said than done, as anyone who treats patients on the call probably knows. But there's more emphasis on that now than ever. There's more responsibility on hospitals and health systems to take the reins on the total cost of care for patients. For those of us in healthcare administration, this is a huge pressure right now, where it's our responsibility to bring all the parties to the table, whether it's post-acute care settings and rehab settings and skilled nursing facilities and physician offices, to try to collaborate on the care of these shared patients to reduce the total cost of care and improve quality. And that's a lot of pressure, because we don't control all those places, yet we are being held responsible by CMS to bring all of them to the table and get everyone to work together and play in the same sandbox and share philosophy on how we're doing business. Teams Bundle is something that starts next year that our health system is being forced to participate in, which is just putting our health system as a responsible party for the total cost of care of all of our Medicare beneficiaries in our community. And that means that we have to collaborate with all of our physicians and others to try to better manage the care of those patients collaboratively. So the challenge with that, and the behavioral health challenges that we're facing now, so it's a whole other level of patient that we're dealing with, is this is a big complex puzzle that we're trying to solve from a healthcare administration standpoint. It includes a very complex network of providers that we now have to bring to the table to work together and have a shared philosophy and shared relationship financially to improve the cost of care for patients and improve the quality. This is where it's becoming important to start bridging the gap on our side. So that's where the next slide, I think, comes in. A lot of these definitions have been coming out from CMS, and these are the words that they're throwing around: value-based care. They define it as paying for healthcare services in a way that directly relates performance to cost and quality and the patient experience. It's all about improving patients' quality of life and adherence to care plan, integrating and coordinating care more efficiently. These are the definitions that CMS is working on. The next one is similar to it on the next slide: population health management, aggregating data on a large population of patients throughout a whole system to try to give shared focus, a shared practice to improve the cost and quality of the care of these patients. What this all means is that this is what CMS is focusing more and more on every year, with new programs and new ways that they are reimbursing us for the work that we're doing, whether you're a health system or you're a physician practice. The problem is, it sounds great and it's worded wonderful on paper, but in practice, it's so much more difficult. And CMS isn't giving us any rule book on how to do this. And it incorporates so many different providers, physicians, and post-acute care networks and hospital systems to all come to the table and agree on how to care for their shared patients, to share data on those shared high-risk, high-cost patients, and for everyone to agree on how the best way is to improve the quality of care and reduce the costs. So it's very complex problems that we are dealing with right now. Our job, for those of us that are passionate about lifestyle medicine, is try to bridge the gap between all of these pressures coming from CMS and the reimbursement models around value-based care and population health management with what we believe is the right way to deliver medicine, which is under a healthcare setting and under lifestyle medicine to really improve the quality of health and the quality of life of our patients. There's a lot of shared infrastructure between those two efforts. We're saying a lot of the same things, but we have to figure out how to check the boxes on what CMS is looking for to make sure they keep paying us in our traditional fee-for-service environment, while we're doing what we feel is the right thing for our patients and our community to really give them a better coordinated system of care and make sure that they have the options in front of them to do the best thing for them and their families to get involved in taking more ownership of their health care. So these are the couple things. I'll go back to that slide real quick. These are a couple things that we've started to try to bridge those gaps, focusing on ED visits and cost avoidance. So that checks the box for all the Medicare Advantage programs and the ACO programs and the total cost of care for the hospital, but allows us also to get into homes and do a community paramedic program to talk to patients about how to be more involved and engaged in their care. Don't just go to the ED, but let's work through what your medication needs are. What are some healthy food choices that we can make? Do you need refrigeration? So this has been a project that bridges that gap. System-wide care coordination, we have a team that is starting to connect the physicians and the clinicians across our system together in a shared model to be able to make sure that we're talking to each other about these shared patients. We've got shared care plans that we all agree on, and we're actually holding the hands of some of these patients through that process. The clinically integrated network is another key part of this, where we're joining together groups of physicians in our community with a shared focus, shared incentives, shared quality metrics to try to get them all on board to, again, talk to each other, collaborate, and improve the total cost of care and quality for these patients that we're trying to help. And the food pharmacy, I know Dr. Albin mentioned a food pharmacy at UT Southwestern too. We started one here with the local food bank that has just been another way to get patients more engaged in the conversation, get them to care more about their health. So now you can go to the next screen. This is some quick data showing the impact of our ED visit reduction. Again, this is trying to bridge those gaps, checking the boxes on the regulatory programs while also getting patients more engaged in their care. We have community health paramedics that go out to homes of high-risk, high-cost patients that visit our ED a lot. Over the course of a year, we reduce their visits by half, which if they are unfunded, it helps on the cost, the charity care that the hospital pays for those. If they're funded through Medicare or other plans, it's helping with some of our regulatory programs, our MA plans, our ACO patients. So that's been just a focused effort that's been successful, and we've continued that. Through our clinically integrated network and our care coordination efforts, we're just trying to build value across the practices that are partnering with us across our system, sharing quality performance incentives, watching for diabetics, managing their patients, doing care pathway support with our neurologists and our primary care docs to do better headache protocols, providing more at the elbow support in our physician clinics to help with some of that burnout where we're asking them to do more. This is providing MAs and care navigators and people that can manage the paperwork at the elbow that are helping us achieve the goals in those MA plans and those ACO plans to get the incentives, but also managing the physicians that have just another thing to worry about, giving them some at the elbow support. And that allows us to talk more about lifestyle medicine and nutrition and get dietitians more involved, because the physicians don't feel like it's all on their shoulders to do that, because they don't have the time or energy and sometimes the skill set to do that in the clinic. Sharing data across the physician platforms is one thing we're doing through our clinically integrated network. We're working on a dashboard that Dr. Patel's been instrumental in helping to build to share quality data with several physicians across our systems who would otherwise not have access to this type of data. That gets them engaged, gets them involved, and really looking at quality of care of these shared high-risk patients. And then also providing payer credentialing, contracting support for those physician practices. It's just another value add to get physicians to talk to us, engage with us, partner with us on some of these quality metrics and lifestyle efforts, because we're offering them a valuable service that they would have to go somewhere and get. So we're just trying to find ways to incentivize physicians through incentive payments for checking boxes, or offering services or value adds like data sharing, payer credentialing, to get them to the table to talk to us, to work and collaborate with us. Patient engagement, I mentioned, is a big part of this. We can't just do all this stuff to patients. We need them to talk to us. We need them to engage. We need them to care about their health again and make changes. Food pharmacy has been one program that's helped with that. We're putting behavioral health resources at the elbow in our physician practices, because we're no longer dealing with the traditional diabetic patient. We're dealing with patients with diabetes and suicidal ideations and anxiety and depression. And many of our primary care docs don't have the skill set, ability, or time to manage these very, very complex patients who have needs that are so much deeper than what's going on physically with their blood work. So providing some LPCs, licensed professional counselors, psychology, and even psychiatric resources in our primary care clinics has been a program we have worked on ever since COVID, since we've seen so much more of this in our primary care practices. And then having care plan nurse navigators also working within this network of clinicians to hold these. Again, we're looking at a subset of patients who are high risk, high cost, chronic disease, multiple comorbidities that they're dealing with. Many times they don't understand their diagnoses. They don't know what's going on with them. You start telling them they need to improve their diet and eat better. They don't even know what disease they're fighting or how to take their medication. So having nurse navigators that can navigate patients and families through what it is they're dealing with, why they have 3 different follow-up physician visits, how do they take medication, how does eating more plants and less meat impact any of this, where can they get this food from at the food pharmacy. So trying to coordinate all of that and really hold the patient's hand through some complex, very hard to understand medical challenges that they're going through has really been key to a lot of these efforts. The next one, I think, is just a final slide summarizing our food pharmacy project. We partnered with the West Texas Food Bank, started in 2024. We actually started talking about this program with Dr. Patel and others before COVID, and this was one of the really exciting programs that were stalemated and halted through those COVID years. And we just finally got it launched in 2024. We've had over 1,000 patients referred. These patients, their referrals are generated upon the inpatient admission. The dietitians are doing screenings on them. And if they are flagged to have 1 or 2 comorbidities that are identified in our algorithm, and they have a food insecurity identified, they're giving a food prescription to the food pharmacy. So out of those 1,000, 84 actually showed up and picked up their boxes. And there's been 212 pickups, which means of those 84 patients, several of them went for repeat. And when they pick up their food boxes, it's not your traditional food bank box. It's obviously fresh fruits, vegetables, beans, legumes. There's no Pop-Tarts or Vienna sausages in those boxes. We do have culinary experts and dietitians on site when they pick up their boxes to do demonstration meal prep, so that shows them how to cook a meal with beans and rice and squash, and how to prepare something tasty with using limited oil and not having to use meat or dairy in the dish. So that's been a very successful, fun program to watch it finally launch, and it's been a great partnership with the food bank. The food bank actually gets funding for this program from the government. It's one of those new programs that came out. I think ACLM shared a list last year of the expanding programs that supported food is medicine efforts across the country, and food banks are one of those that are getting some of that funding. So if you don't know about that, check in with the ACLM on that list of funding opportunities that are available through those new efforts. And your local food banks, your local city governments, others have access to those funds to help expand programs like this. I think that was my last slide. I'm sorry, I try to go through that quick. Again, it's so much that's happened over the last several years. I don't want to downplay any of it because a lot of it took a lot of time and effort. I'm just hoping to paint a picture of a summary of things that we did that worked for us, for our organization, to give you some ideas and options. It will obviously look different for all of your organizations. But at the end, I'd be happy to answer any questions about any of that. But before that, we have Dr. Richard Chamberlain, I believe, up next to take over.
Good afternoon or good morning to those that might be joining us from the East Coast. Thank you very much, Mrs. Madrid, for the introduction. Thank you to the American College of Lifestyle Medicine for the opportunity to join, and it's such a pleasure to be in the presence of these wonderful, wonderful leaders in their areas. Next slide, please. And so this slide, you'll be able to see the Laredo Public Health Department. Some of it, there's still more on the north side and the south side that do not fit into this photo, but that is somewhat of an aerial snapshot of the Laredo Public Health Department, where we're trying to transform community health through lifestyle medicine. Next slide, please. A little bit about myself. I am the Executive Director and Public Health Director for the City of Laredo. What does that mean? Of course, I am the Director of Public Health for the City of Laredo, but I also oversee the operations for our only municipally run detoxification facility in the state of Texas, our animal care system, and our library system. Lifestyle medicine reached me in 2022 when I also had a little bit of a personal journey with some bad chemistry that came in that year. Of course, there wasn't a lot of attention being focused on my personal health throughout the pandemic as we were responding day in and day out, 24/7, 365. It was a marathon with no end in sight at that time. But of course, that came to an end in 2023 with the official designation of that well, we can move on, but of that emergency declaration as well. And so during that year, my chemistry came back. It wasn't all the best, and I started looking for new knowledge, education as to how I can empower myself, but then ultimately those around me as well. Therefore, I found lifestyle medicine in 2023 and decided to challenge myself to become certified as well in lifestyle medicine, which would only help to elevate the public health department's operations and those around me as well. I started that journey. Unfortunately, I wasn't able to sit and test in 2023, but I did share this information with one of our staff members who's part of the senior executive team here at Laredo Public Health, our clinical services administrator and internationally board certified physician, about the opportunity, which he continued to pursue in 2023 and successfully obtained the credential for himself and ultimately the city of Laredo and Laredo Public Health in January of 2024. I followed that up with being certified as well in December of last year, and officially, of course, provided the response in January of this year, which was very rewarding and just so much information that helped me make several changes in my lives that were simple, easy swaps, step by step, small steps make a significant difference in the long run. And ultimately, my chemistry was turned around within 8 months of dedication to the process. Physical activity, sleep, stress management. I mean, I'm preaching to the choir. Just made sure to really, really start to practice that and ultimately practice what you preach. And earlier what Dr. Albin said really resonated with me about being the leader. People observe and they'll start to ask questions. And that's exactly what started to happen with me in my personal life and ultimately around the public health department. Next slide, please. And so why lifestyle medicine and public health? We know that there is a chronic disease epidemic in the United States where 80% is preventable through lifestyle change. That root cause, that poor nutrition, inactivity, chronic stress, poor sleep, risky substance use, and social isolation are causing the exacerbation of these chronic diseases, and that lifestyle medicine is prevention in action, which perfectly aligns with what what everyone's public health mission is, which is promote, protect, and prevent. We traditionally know that public health has been very reactive to many situations, but we truly don't want to be upstream. We want to be coming out of groundwater with attacking these root causes. And ultimately, it supports health equity by addressing social determinants of health. Next slide, please. And so the case for lifestyle medicine at public health. So it addresses root causes, as we just talked about, not just the symptoms. It improves population health outcomes and lowers long-term costs. It scales across programs from maternal to infant to child health to school health, chronic disease prevention, community wellness, you name it. In the foundational public health services and programs, lifestyle medicine can be a part of it, and builds community resiliences for crises such as pandemics or extreme heat, etc. Next slide, please. And so our commitment at Laredo Public Health is that we have integrated lifestyle medicine practices across all foundational public health services and programs, that any new initiative is designed from the ground up with lifestyle medicine principles composing that scaffold, that we are cross-training staff in the 6 pillars of lifestyle medicine, and we are partnering with local providers, schools, and community organizations to get this word out. So to give you a little bit more perspective about Laredo Public Health is a mid-sized health department with a total of 310 staff members, providing more than 45 different services and programs, including all foundational public health services and programs, but several specialized programs and services as well. And so we are getting into the fabric of all those to ensure that our staff, especially the leadership and trickling downward, are firmly invested in this mission. Next slide, please. Recently, we enacted and started up our Lifestyle Medicine Community Challenge. Last year was the first year in 2024 where our mayor addressed a group of community residents at one of our recreation centers. Because we've been speaking about it with the mayor of lifestyle medicine, he brought it to the attention of that community group at the recreation center, which did gain some traction and ultimately made it onto the evening news in 2024 in January. As we continue to roll out lifestyle medicine across the city of Laredo, this past May through August, we instituted the Lifestyle Medicine Challenge, which is something that we'll continue to host on a yearly basis, as from the participants, they are asking for more after this concluded, which is absolutely wonderful to hear. So the goal was to engage the community adopting healthy habits through the 6 lifestyle medicine pillars. Participation was all adult age groups from diverse backgrounds. The vast majority, though, were between the ages or above the age of 35 who did join the Lifestyle Medicine Challenge. The key learning that they were able to take away from here was the strong engagement in stress management and nutrition and social connection, and that participants reported new sustainable habits, more activity, better diet, therapy, engagement, and improved sleep. And there's some photos down there of some of the participants at the end of the challenge for participating. We wanted to make sure that we were going to contribute to their continued success in the physical activity realm. So they were provided with those door prizes for their participation. But ultimately, being able to get out into the community, invite them in, and be part of this lifestyle medicine challenge was such a success, as we broke down those 6 pillars into 10 modules. Those 10 modules included what is lifestyle medicine, physical activity, let's talk water, choosing the right fitness app, understanding food labels, the crowd out method, managing stress, sleep better and unplugging from screens, building social connections, and avoiding risky substances. And results were that proof that lifestyle medicine works when made accessible and culturally relevant. Next slide, please. And so, as mentioned, these outcomes were very rewarding for us to see at the administrative level, as they did report increasing their physical activity and water intake, that they were especially within our culture here in South Texas, which is a very homogeneous Mexican American population, it's not very easy for people to talk about how they're feeling. And I think that transcends many different cultures as well. But here, just being able to observe and get the feedback that they're talking more and that they want to be connected to a counselor or a therapist was just very rewarding as well. Of course, they're eating healthier, prioritizing better sleep, and that there were early signs of behavioral change in under 90 days. Next slide, please. The Public Health Provider Charity Care Program. For those, of course, that live in the state of Texas, this came about after the 1115 DSRIP waiver for public health departments was dissolved a couple years back. And so this program was put into place to allow public health providers that run primary care operations like we do here at Laredo Public Health, allow them to be able to get reimbursed for the services that we provide. And so this was also part of our journey as we started with lifestyle medicine practices, as mentioned in 2023, by learning about it. At that time as well, I was able to connect with the budget process and already starting to put this into motion, submitted for a public health promotion specialist, a medical office assistant, a nurse, additional funding for a mid-level provider. And we were very fortunate that the city of Laredo responded to our request and awarded us those roles as part of the general fund here at Laredo Public Health, amongst others. Knowing that we wanted to use those roles in the future of our charity care lifestyle medicine program, which have to be general fund by those local jurisdictions. And so we are now at the cusp of actually launching our primary care lifestyle medicine program for our under and uninsured residents. But most importantly, this is for everyone. We want everybody in the community to come and take advantage because we truly now have all the elements underneath one roof. We have our primary care provider, our MD, our mid-levels. We have our harm reduction specialists to be able to help with the prevention or preventing the use of risky substances. We have our LPCs in-house as well that are able to provide counseling and also connect them directly to our telepsychiatric services if necessary here in-house as well. Our public health promotion specialists are working towards certifications for physical activity as well. Our WIC director, who also will be pursuing her certification sponsored by the city of Laredo in lifestyle medicine, who is a registered dietitian, is jumping on board as well. So we have that clinical aspect. And of course, that dietitian as part of the food element or the nutrition element in this program. The LPCs also help with the stress management as well, and we're partnering with a sleep specialist at our local university to be able to come in and help provide that level of education to the participants of our public health provider lifestyle medicine charity care program. And overall, our goal is to break the cycle of preventable disease and reduce the uncompensated care costs that so many are experiencing. And so as just going back to that, having all the elements underneath one roof, we know and believe that we will see that value-based outcome for these individuals, which then will serve as lifestyle medicine ambassadors in the community to be able to further push the message and drive that change. Because here in Laredo, our report card for health overall is not in the best standing, but we're making those small steps every day to improve our population health. Next slide, please. And so why this matters, it reduces preventable hospitalizations. It empowers residents to self-manage their health. It strengthens health equity and social cohesion. It makes every public dollar go further by shifting to prevention versus reacting to the situations of our chronic disease prevalence. And it creates a model for other, not just border cities, but cities that they can replicate this to. Next slide, please. And so lessons for other communities. Integration. Lifestyle medicine can be integrated into existing public health programs without massive restructuring. I would encourage the participants of today's webinar to reach out to their commissioners, to reach out to their city council members, to reach out to their public health directors, and start the conversation about lifestyle medicine at the population level as well. Start with a low cost, high impact challenge, just like we did, to build the trust, momentum, and awareness within the community about lifestyle medicine. And measure behavioral change, not just participation. As mentioned earlier by Ms. Madrid, value-based systems are what we truly do want to see. We want to make sure that A1C levels are going down, that cholesterol is in check, etc. We don't just want to be paid for participation. No, we are not paid for participation. We are paid for value-based care. Next slide, please. And so lifestyle medicine isn't optional. It's a foundation of a healthier, more equitable future. And investing into lifestyle medicine as a core public health strategy is where we all need to be. So partner with schools, employers, and local providers, bridging those gaps, as mentioned earlier, so if those providers or systems don't have all the elements underneath, that's where public health can come in and help support those independent organizations. And measure the impact, share success stories, and join the movement to transform community health from the ground up. Next slide, please. Thank you very much. We'll stand by for questions.
Thank you so much, Dr. Chamberlain, and to each of our distinguished presenters. I've loved learning about the diversity and impact of your respective lifestyle medicine efforts. And this has already been such a lively webinar. I can't wait for Q&A. To that end, I see a flurry of excellent questions and feedback in the chat. So for our presenters, as I walk through the next few slides, if you want to review some of the Q&A that came in, answer any that you'd like to type responses to, feel free to do so. Before transitioning to Q&A, we wanted to also make sure that those on the webinar are aware of some of the resources we have available at ACLM to support some of the strategies described today. One of the foundational ways to learn more about lifestyle medicine and food as medicine is to enroll in our complimentary 5.5-hour CMECE Lifestyle Medicine and Food as Medicine Essentials course, which each of these leaders have socialized within their networks and is available for free until September 14th. So about 2 more weeks to take advantage of that. Simply scan the QR code or visit the URL on the slide to get started, and feel free to share that within with any others within your network. If you're not already a member of ACLM and on this webinar, we would love to have you join. Our members are united in leadership to transform healthcare and make a lasting impact on addressing the root cause of chronic disease. Our outstanding speakers here today are a really remarkable example of the type of impact that many of our members are commonly leading. Feel free to explore the QR code for more information about becoming a member. As Dr. Patel mentioned earlier today, we would love to engage with all of you at our annual conference, LM 2025, in Grapevine, Texas, as well as online. There will be some really exceptional content pertaining to a broad range of topics and similar stories of healthcare transformation through lifestyle medicine as what you've heard today. And if you'd like to hear more from Drs. Albin and Patel, who will be speaking, it's a great way to both learn more about their work and connect with other like-minded leaders in the field. There are more than 8,000 physicians and clinicians globally who have become diplomates of ABLM, IBLM, or ACLM, including each of our distinguished presenters today. Becoming board certified is an outstanding approach to gaining and demonstrating knowledge and implementing therapeutic lifestyle interventions within clinical settings. You can learn more about becoming certified by following the QR code linked here. Hot off the press, as of Monday this week, ACLM is also very excited to be able to offer a complimentary culinary medicine program based on the foundational work of Dr. Michelle Hauser. It's an amazing resource library exploring foundational kitchen knowledge, basic cooking skills, delicious recipes, and much, much more. And it's suitable for both experienced home cooks as well as those who are new to the kitchen. Feel free to explore the linked QR code. And so now we have just over 15 minutes left, almost 20, and we'll turn things back over to Dr. Patel, who's moderating a fantastic live Q&A session with our phenomenal presenters. So Dr. Patel, over to you.
Thank you, Tyler. And before we move on to our Q&A session, I want to thank Jacqueline, Marcy, and Richard, for their trailblazing leadership. I really value your passion for lifestyle medicine and for your commitment and perseverance. I mean, your words resonate so well. This is not easy. The journey is not easy, but I want to say your work is truly inspiring. So, Marcy, let me start with you. You were instrumental in helping Midland Health's leadership embrace lifestyle medicine at a time when it was still seen as sort of unconventional. From your experience, what strategies were most effective in engaging leaders and bringing them on board with this vision? And what advice would you give to others who are trying to cultivate something similar or trying to kind of cultivate that type of leadership within their health systems?
I'll speak to that as I normally do, but I really appreciated Dr. Albin's, because she made two comments that I'm going to repeat that I think speak directly to this. And I believe actually Dr. Chamberlain mentioned this too. Sharing personal stories goes a long way to get people's attention. My personal story, I think, went a long way with my peers to say, hey, this happened to me and this is what's going on and I'm so much better. And don't you wish all of our patients and families had options like this? So I think that was a good way to get their attention. Two, I think her follow-up point was you got to show data. You have to have some follow-up to that. I think that's certainly important, although that took a while for us to gather. I think the next most important thing that we had to do was connect the dots to what our current struggles and issues were as a health system to what we felt were the right things to do for our patients or as it related to lifestyle medicine. And our key focus to begin with was employee benefit cost, because we were self-insured as an employer. We carried the cost of the benefit plan, and we had seen, that many employers can look at their data if you're self-insured and see that benefit costs have risen more every year. They're higher and higher and higher. They never go backwards. And so there was lots of opportunity to reduce overall benefit cost, and prescription drug cost were just astronomical. And so we really had a focus on, if we can really do a focused effort on our employees and truly make our employees healthier and their dependents healthier, we can have tangible monetary impact that is doing the right thing and also saving us money. So that was our focus to begin with, because we just had to find something that was helping people and doing what we felt passionate about, but would have some type of direct return on investment on the business to keep our financial leaders involved and engaged. So really focusing on our benefit plan was where we started. Our next population we focused on was, okay, where else can we have a financial return? Well, we are a public not-for-profit healthcare system, the only one in Midland, Texas. We carry all the charity care costs. So when patients aren't insured or they don't have good payers and they're really sick and they have a lot of ED visits or long inpatient stays or complicated diabetes, we are responsible for those unpaid healthcare costs at the end of the day. So if we can focus on our really high risk, high cost, complicated patients and deliver better care and get them more engaged in their care and give them options like a food pharmacy prescription or some better navigation of choices and have them reduce their ED visits by a little bit, or reduce their length of stay by a little bit more, or just improve their overall health and reduce the result of amputation because their diabetes wasn't controlled. Things like that help us with our charity cost of care. So I think the most important things, and again, I believe Dr. Albin mentioned this beautifully on her slide too, is find what the current efforts are of your health system leaders that you're trying to partner with and figure out how you can draw a line to what you know is the right thing to do, what you think your community needs, to what they're focusing on financially or from a strategic initiative perspective. And if you can speak that language that they care about, then you can gain some momentum and some alignment.
Yes, and I couldn't agree more. Having that strategic alignment with the leadership is really the key here. Yeah, so Jacqueline, moving on to you, question I have is, how have your patients responded to lifestyle medicine approaches? Especially, how do you tailor lifestyle medicine approaches to meet the needs of diverse or underserved populations in Texas?
Absolutely. So I didn't really share this background, but I am both a pediatrician and an internist, as well as having certification in culinary medicine through the American College of Culinary Medicine and board certification in lifestyle medicine. And so those came later for me, and that was after practicing primary care across the lifespan for a long time at both Parkland Health, our county system, as well as UT Southwestern and our children's hospital, where I worked with children who were in foster care for the first 3 years of my career who had experienced immense trauma. And so I've literally worked with every population across every socioeconomic background, across every age. And I think it is so vital to understand food and lifestyle through the lens of people's stories, and that many people have very little control or choice that drives the behaviors that they have. And let's look across the board. If you actually look at the data on dietary quality, are people with choice making better choices? They aren't, right? So even people who have food choice, that have resources, that have education, are still struggling because the system sets us up to fail. And so I think we all have to be very careful about relinquishing any form of judgment and coming at this problem as our patients are just, it's like Dory, just keep swimming. They're just trying to get through the day and take care of their families. And so if you approach it with curiosity, people will tell you why they can't do it. And I think that we have to then help them overcome those barriers with small steps. We cannot be dogmatic about you have to eat exactly like this, or you have to eat this flavor profile. We have to understand that any positive change is better than staying where we are. And so I think it's really about understanding enough about where someone's coming from before you give any advice. So I actually train my residents and students that, yes, I want you to talk about food and movement and all these things, but not until you know who your patient is, where they're coming from, and what their load is. And so I love specifically asking about someone's relationship with food. And that question opens up all of the things that are under, they're using food for comfort because they have untreated depression, or they don't have a lot of choice around their food and they're doing the best they can. And so I just believe that when we step back, we get out of the algorithmic approach to medicine, which is really what culinary medicine has allowed me to do and why I love it so much. I can talk about food for longer because it's a focused primary care integrated approach. And I can actually understand, oh, okay, well, you only know how to use a microwave. Is it culinary literacy that's the barrier? Is it food access that's the barrier? Is it transportation that's the barrier? Then we can go after addressing those things and be much more effective. We cannot continue a one-size-fits-all dietary advice and expect it to work for everybody. Food is more than just health, too. It is also culture and family and tradition, and we must respect those aspects to be successful as well.
Wow, beautiful said. Thank you, Jacqueline. Richard, as an adjunct professor, I know you mentor future public health professionals. What messages or skills do you feel are most important to pass along to students who will carry this work forward?
It's a great question, Dr. Patel. So this semester, I'm proudly spearheading or instructing our public health systems course at Texas A&M International University. And within the public health systems course, I do make mention of lifestyle medicine as I would like for them to slowly start to understand these 6 pillars and how they shape the rest of their lives. We know the vast majority of college-age students are between the ages of 18 to 25, but of course, learning is forever, and we do have many individuals who are not between that age range that can also benefit from learning lifestyle medicine pillars at any time, just by putting these into practice. And so by sharing the information about lifestyle medicine with the students, it is our hope that ultimately they are able to prevent chronic disease by looking into what small steps or small swaps in their lives they can do to ensure longevity, but with vitality. We want to make sure that we do have vitality in our longer lived lives and we're able to care for ourselves. So ultimately, I let the students know that the decisions that they are making today, while they might not have put too much thought into having that deep fried chicken breast in their sandwich today. But if they start thinking about that and making swaps and not saying that they can't have those things, but that they can just portion them out and do it every so often, allows them to still enjoy the small things in life that may not always be the most nutritious as well. And so we're working towards that here at Laredo Public Health, and of course with that integration with the students of the public health program at Texas A&M International University to further the lifestyle medicine initiatives and messages.
Very good. Thank you. So here's a live question for perhaps all three of you to chime in here. What are the critical success factors related to expanding and scaling lifestyle medicine nationally and globally? Clearly, there's a great work already happening in Texas, but what advice and tips and strategies you think are necessary?
Well, I think it's happening, right? I mean, those of us who were thinking about these things 15 years ago can look at it now and say, we felt stuck then. And everyone thought, frankly, that we were crazy. I've even had people tell me I was wasting my medical training by teaching patients how to cook. But now you see it exploding everywhere. So the first thing I would say is, again, back to rooting it in the need. What is the need in your community? What is the need in your health system? How can this be part of the solution? And then when you simply pitch that, not once, not twice, but sometimes 15 times, it will land at the right time with the right people. So I think it's keep showing up, keep saying the same thing, make your little TED talk and tell everyone who will listen. You might be a little bit annoying, it's okay. And speak about your personal stories. As Marcy and we've all shared, the personal roots are deep. If someone shares a personal thing, jump on that as, oh my goodness, lifestyle medicine might have a way to support what you're doing. And then I always say we judge leaders harshly for thinking that they don't listen to us or they aren't paying attention. But you have to remember that most leaders, whether it's like an academic medical center where I'm at or any health system, any district, any public health department, they have a million tabs open on the brain, on the mind, many, many worries, many competing demands. So sometimes when we bring forth an idea and we think they aren't listening, it's not that at all. It's just that maybe there's something more urgent that has to be addressed right now. So come back again in a month. I often send emails whenever I see something that might be an opportunity. I send emails to the relationships I've built with leaders, and sometimes it lands and sometimes they might not respond, and that's okay. So be willing to keep putting yourself out there with brief, relevant, kind of rooted in the mission and vision of your institution information, which takes homework, like we talked about, and then eventually it will be the right place at the right time, and then they will be coming to you to say, hey, didn't you say you were interested in this? It takes a lot of patience and a lot of persistence. But we're
Yes.
scaling. It's happening everywhere.
Clearly, it's happening nationally. It's also happening globally. You're right. Marcy and Richard, anything you would like to add?
It's really hard to add to that because I feel like she touched on a lot of the main points. I think we've already said this, and I can't repeat this enough, and I'm sure those that are on the call that are involved in healthcare know the healthcare system is kind of a mess right now. I mean, there's so many competing issues and problems and broken areas that we're trying to fix. I mean, I couldn't even get into all the details of the things that we're going through on our slide, but I mean, trying to work within a system that's forcing physicians to see more patients to justify their pay, yet we want to make people healthier and give physicians the time to talk about depression and identify, unmet needs socially and social determinants of health and all these things. I mean, so many competing priorities, and we've got so much going on that's not working. Don't mention the insurance companies, the pharmaceutical companies, and their competing interests a lot of times. It takes creativity, it takes patience, it takes coming up with small solutions, again, realizing the people that you're bringing these things to do have a million tabs open and all these conflicting interests, and trying to find creative ways to maybe start small, do small tests of change, work on problems in a small area that can eventually be expanded. So many of those points on my slide, like ED visit reduction and clinically integrated network and care coordination. I mean, it sounds like it's a lot of these big things happening a lot of places, but within all of these big projects, there's some little underlying lifestyle medicine component that we're sort of planting seeds in to try to spread seeds as far and as wide as possible to help this movement and this information grow from all these different projects and places and areas where we're trying to check the boxes for Medicare and for CMS and for the insurance companies and for our administrators. I think that's where the creativity and the patience and knowing the right language to speak comes in. Like, oh, we've got this big project and we're doing all these things, and let's slide in this information as we're talking to patients, or let's provide this resource to our physicians to make sure that they can have a food pharmacy option. It's all of that together.
Yeah, and I couldn't agree more, but I wanted to just also emphasize some of the work that I'm involved with in advocacy. On behalf of ACLM, we've made significant strides with CMS and CMMI with their new three-pronged strategy that they released in May is all about lifestyle medicine. And so that's very encouraging for the first time in the language of CMMI strategy, focusing on lifestyle medicine, evidence-based promotion or empowering individual on their healthcare journey. These are core LM principles. And most importantly, in the proposed 2026 fee schedule, we've seen some very exciting questions around payment models, care models for lifestyle medicine, and a lot of questions are RFI that we will be submitting and comments, which is very encouraging as a field. So yes, there is a clear momentum that's building, and we're very excited. With that, we just have 1 minute for this webinar. Thank you to all my speakers today, and I'm gonna pass on to Tyler. Back to you.
Wow, thank you so much, Dr. Patel. What an outstanding webinar and discussion. Those were some really amazing questions and insights shared by all of our presenters. And judging by the chat, I imagine we could keep this conversation going indefinitely. Since we have hit the 90-minute mark, we'll officially close out today's webinar. But on behalf of ACLM, I want to sincerely thank Dr. Patel for her fantastic moderation, each of our distinguished presenters for sharing their remarkably impactful work right here in Texas, and to all of you in our audience today for being so engaged and asking such outstanding questions. So the innovation that's happening here in Texas is truly inspiring, and if it can happen in Texas, it can happen anywhere, right? So we look forward to staying connected as you bring today's recommendations and insights into your practices, and hope to see all of you at our annual conference in Grapevine this fall. In the meantime, please visit our help center and website if you have any questions that we weren't able to get to during the session. But with that, thank you so much all for joining us today. Wishing you a wonderful afternoon ahead. Thanks so much. Take care.